All right, everyone, thank you so much for joining us for our next or our current IIH Practitioner Series. Today, we are very lucky to have Dr. Mark Kupersmith, who will be presenting, and Dr. Pierre Gobin, who will be moderating. Dr. Kupersmith is one of the most famous neuro-ophthalmologists in North America. He's decades of experience in treating and conducting research on a wide range of disorders, including IIH. He's a clinical professor of ophthalmology at Mount Sinai and New York Eyes and Ear Infirmary. Research is a key part of Dr. Kupersmith's career. He's director of Nordic, which is the clinical trial network for neuro-ophthalmology. He's also leading a multi-institutional research team to study visual field changes, optic nerve head imagery, and optic nerve head imagery using AI and other bioengineering methods. His focus is on predicting vision loss severity and also monitoring the effects of therapies. He's known for problem solving for complex cases and unknown vision loss. Thank you, Dr. Kupersmith, for being here. We really appreciate it. Dr. Gobin specializes in interventional neuroradiology and endovascular treatment of cerebral aneurysms. He's one of the inventors of the concentric Mercy retriever, a device for removing blood clots in the brain that causes strokes, and the River Stent, an investigational device designed for treatment of IIH. Dr. Gobin is the director of Interventional Neuroradiology at New-York-Presbyterian Hospital, Weill Cornell Medical Center, and professor of radiology and neurological surgery at Weill Cornell Medical Center. Pierre is also CEO of Serenity Medical, developer of the investigational stent, River Stent, and the sponsor of this webinar. Thank you, Pierre, for being here. Let's turn over to both distinguished physicians.
Thank you, Barak. This webinar is supposed to be open to the public, and everyone is supposed to ask questions. We are very lucky today to have Dr. Kupersmith with us. All the attendees can ask him questions. Do this through the chat, please. And I'm going to start. Dr. Kupersmith, what made you so interested in IH that you have designed clinical trials, you have published on it? I mean, why this special interest in this disease?
Well, as a neuro-ophthalmologist interested in how we see, not just at the level of the eyeball, but interested in how the brain works in neurological dysfunctions, this was and I quote, a no-brainer to make a decision like this, because patients lose vision. There was no uniform way to address the problem. Clinicians in different specialties approach the problem really without much real understanding of the pathophysiology or the mechanisms of disease or what was the best treatment. So it seemed like a natural issue to try to investigate at multiple levels to try to shed some light on this. And so much of our medicine is not based on really good science. It's based on individuals' clinical experience. And no matter how vast that is, we know that's subject to flaws and biases. So we wanted to put some science to this disorder. In addition, of course, quite frankly, young, overweight women who were pretty much neglected in healthcare was a natural to study and a natural to get NIH, National Institute of Health funding, because it was an underserved community. So there, I could go on for hours about why we're studying this and what's fascinating about this. But I think you get the global issues are as I stated.
And how can you lose vision in IIH?
Yes, it's a very interesting, and I will tell you, I think we pretty much know what happens, and that is you get the buildup of pressure in the head And that pressure outlet is down into the optic nerves, which of course are the video cables that connect the eye to the brain. And that pressure transmission chokes the optic nerve as it leaves the eyeball, the back of the eye called the sclera. And in that area, it's pretty rigid. And the chronic compression of increasing the pressure behind the eye in that space around the optic nerve causes the axons, which are the little fibers that connect the eye to the brain, and there are 1.2 million of them in each optic nerve, to get crowded, congested, leak fluid, and then secondarily, there's probably vascular and other injuries that occur. So it's basically the thing we worried about is optic nerve damage. The other issue is sometimes all of that swelling spills out literally into the eye, into the surrounding retina, which is like the film of the camera when you're seeing, and the fluid itself distorts the retinal mechanisms, and that fluid causes the visual disturbances. But that we're not so worried about because that tends to rectify or normalize and improve once you get the interface pressure under control. Whereas optic nerve damage is often permanent. Could be slight, it could be moderate, it could be total.
I have a question that may be difficult to answer. It's a question that I've often wondered about it. Why I see some patients that when I measure their intracranial pressure by venous measurement or by opening pressure on the LP, and they may have a very high pressure. However, they have minimal or no papilledema. So, do we have an explanation for that?
Look. So one of the problems with investigations in humans is, of course, the paramount issue is safety, and sparing the patients all kinds of side effects and aggravations and pain. So we do not have a good mechanism to monitor the intracranial pressure over time. We can monitor it at one point in time with a lumbar puncture or when you're doing intracranial measurements. But unless you put a device inside of the head, which is necessarily an invasive procedure, our pressure measurements are indirect and just spotty. And that's why one of the holy grails for monitoring patients with intracranial pressure elevation for anything is to find a non-invasive way to monitor. And we thought that some of the work we've done in research in the eye would do that, but it really hasn't borne out, not reliably enough. So there's a problem getting data. Okay. So I will tell you is that like blood pressure, intracranial pressure fluctuates. It goes through peaks and troughs. So if you do the lumbar puncture at the time when you're at the peak, you get a very high pressure. If you do it at the trough, you say, wow, this person has terrible papilledema and IIH symptoms, and the pressure is not very high. So that probably explains the lack of correlation, is just inability to get the proper data. The last thing that I have to say about that is that the pressure gets transmitted from the intracranial space down into the space around the optic nerve. And there may be some anatomical differences in some patients. There's some work done out of a colleague of mine named Killer in Switzerland. Maybe he's on the call, so I give him a shout out. And that seems to show some difference in the subarachnoid space, but not everyone agrees with this. And it's difficult to prove by all of our non-invasive methods. And fortunately, patients don't die, so we don't really have too many neuropathological specimens.
We have a question from the audience. How do you differ? I am a neurologist, and sometimes I found difficult to differentiate between IIH and optic neuritis. History, fundus picture, even OCT may be confusing and contradictory. So
So
your comment on that?
yeah, that's a very good question, and it's a very important question. So there is clearly overlap between all the disorders that cause swelling of the optic nerve head when you look in the eye, when you do ophthalmoscopy or fundoscopy or take a fundus photo or do OCT, the optic nerve head region. There's overlap. And so the question is there anything that absolutely distinguishes one disorder from the other? Well, first, optic neuritis in 99% of the cases is in one eye. So it's acute and in one eye is associated with pain and eye movement in over 90% of patients. And that's because there's inflammation in the optic nerve sheath. So whenever the eye is mechanically moved, up, down, sideways, there's causes pain. And so it tends to cause fairly significant central vision loss to begin with, although it can be subtle. So that's whereas intracranial hypertension can be asymmetrical. You may see a little swelling in one eye and marked in another, but it tends to be almost always bilaterally. Unilateral cases are rare. We published a paper on this decades ago with strictly unilateral papilledema. So if it's only unilateral, the chances of it being an optic nerve problem is much more likely than it being papilledema. And then there are other ways. The MRI scans in intracranial hypertension, besides showing a partial empty cella, which could be nonspecific because women who've had multiple pregnancies might have that anyway, but the optic nerve sheaths tend to be dilated in intracranial hypertension. You don't get enhancement of the optic nerve sheath, but in optic neuritis, whether it be garden variety, idiopathic, MS, or even MOG, antibody positive studies, they tend to have abnormal enhancement of the optic nerve and the optic nerve sheath. So you're right, there's a lot of overlap, but there's a lot of ways to differentiate. Can you tell absolutely in every case, particularly if it's subacute? No.
Completely different question. Patient who say that she had a stent put in her right side, so I suppose it's the right transverse sinus, in January 23. My pressure and my optic nerve have stabilized. So I suppose that lumbar puncture and papilledema all have normalized, but I still have symptoms. Pulsatile tinnitus can be still severe at times. She gets very lightheaded multiple times a day. She's still taking 500 milligram daily of Diamox. So you have sent severe patients to surgery, to shunt or stent probably. And what do you do when the symptoms do not resolve completely like this? I mean, this patient with papilledema has resolved. That's kind of a success in terms of ophthalmology, but the patient is unhappy.
Yes. So first off, in every disease, there are those groups of patients who will get either no response or not a perfect response to every intervention, and that the public has to understand. What we worry about in terms of being aggressive about treatment is the papilledema associated with vision loss and having severe headaches. The pulsatile tinnitus, there are a lot of disorders that cause pulsatile tinnitus that are not IIH, and that's becomes a problem using white noise and other non-invasive ways to treat them. Of course, Pierre and I have not seen the pictures, so we don't know the extent that the stent was effective. We don't know the extent that what the other anatomy was on the other side. So it becomes a little bit problematic. We can't We can't diagnose and treat you. I would say, however, that 500 milligrams of Diamox once a day is what we would pretty much say is a homeopathic dose. It doesn't do much. It doesn't really lower the intracranial hypertension at all. But there are patients who swear that it helps them, and I never argue with patients when they say I'm having side effects I can't tolerate, or if they say a drug is effective, even though we know from a mechanism point of view, there's no way it should be effective. You know, and then of course we'll get to the heart of the matter, and everyone on the phone knows, on the call knows, that intracranial hypertension in 90+% of the patients are women, and close to 100% are overweight. May not be markedly obese, but being overweight is a risk factor, and you don't have to be overweight by much. In some people, their metabolism dictates that they not be overweight at all. And I have seen about 4,000 patients with IIH, and I know exactly who they are. 4 cases who never had, and who had either no increased weight above what they should have been by BMI, or they were just slightly overweight. Only 4, but it can occur. So that's, of course, if you're looking at having symptoms you're really bothered, then maybe some weight loss might be a recommendation.
A patient is asking if high-dose Diamox, I suppose she's taking 3 grams per day, 3 grams per day. How safe is it long term?
Well, the study that I ran that study on this. Mike Wall was the study director, but it was the proposal and the grant and everything else. So I oversaw that study, and we used 3 to 4 grams. And that study was a very selected cases of people who didn't. All of them had vision loss. Everybody could be in the study had vision loss, but it was looking at mild visual loss. We didn't look at moderate or severe, and we didn't look at anyone who had no vision loss. So in that caveat, we had people on this, but the study only lasted, I think the outcome was a year or 18 months, although we did continue to follow those patients on those doses in a secondary study called LIGHT, which we were funded for, and it seems to be safe. So, of course, everyone knows the potential side effects with any type of medication, but what happens is the body tends to equilibrate, the kidneys tend to equilibrate. So the only real long-term risk factors that I know of might be the development of kidney stones. And it isn't necessarily dose related. Patients who tolerate a gram tolerate 3 grams or 4 grams. Patients who do not tolerate a gram will obviously never tolerate higher doses. But it is, we published a safety paper on this, but I will tell you, from a drug's point of view, it's long-term, but from a patient point of view, there's no long-term data on it. The only thing yet I want to mention is not at those doses, but this drug was approved 80 years ago for treatment of glaucoma, and the dose they were using was about 1 gram a day. And people for decades were on 1 gram a day with no significant problems.
Okay. And another question from a patient. I have a LP shunt, lumboperitoneal shunt, and I am still severely symptomatic. I have had several lumbar puncture that show that my ICP is still high. My vision is bad. My papilledema is
I'm sorry, the vision is what?
bad.
Oh,
I don't know exactly that's
yeah.
what the patient wrote. My papilledema is back, and optic nerve is still swollen. Well, I would answer that the LP shunt probably is not working, but can you elaborate?
So
Yeah.
Pierre hit it on the head. He took it, and so for those who on the phone know me, know I'm not a very good diplomat. I hate LP shunts. I hate LP shunts, and a couple places really like LP shunts, and I can't figure out why. Because when they put it in, you never know if it's working. There's no mechanism to test it. They tend to fail at a higher rate. They get covered. They get packed in the omentum from the abdomen. Get packs in. They tend to separate. So clearly, whoever that LP shunt is not working, and you need another therapy, whether it be a stereotactic VP shunt or high dose medication or a stent. But you need something other than an LP shunt. And I will tell you is that most of the people who treat IIH in the country, the neuro-ophthalmologists, also don't like LP shunts for the same reason. And also there's a higher infection rate. So I'm as you can tell, I'm very biased by my experience and others' experience on this. And unfortunately, I think it's time for you to pursue another therapy.
Okay. Let me see. We have so many questions, and some are really long. So, some really bizarre question. Very interesting. What do you do if the MRI showed tortuous optic nerves, flattened sclera, empty cella, but the patients have no clinical symptoms of IH and no present papilledema?
So that is actually a very relevant question, Pierre. And the answer is well known. And I'll explain why. So first, we couldn't, as neuro-ophthalmologists, we couldn't get the neuroradiologists to read the pictures, and they would always pass patients as normal who had these subtle signs that you just mentioned on this. Now everybody reads them, and every neuroradiology report says clinical correlation reported, but this is suggestive of pseudotumor cerebri or intracranial hypertension. But there was a very good study in JAMA Neurology about a year or two ago out of Emory, where they looked at that issue of hundreds of MRIs and realized that these findings, unfortunately, were common in the population. Not so much the scleral indentation, but the other findings are very common in the population. So if the patient has no findings and no symptoms, do nothing and except monitor them expectantly. I wouldn't send them for a lumbar puncture. Why would I do an invasive test in somebody who has no symptoms? Because what would I do about it if I found the pressure up? As long as they're asymptomatic, we don't treat them anyway. This goes back a long time ago, is that again, maybe prior to MRI scan, how we used to treat people. And we take people eventually off the medication, they lose weight, their papilledema goes away, they have fewer or no symptoms. And then someone would have headaches and go back and with no papilledema 10, 20, 30 years later, and still find that their intracranial pressure was still elevated. So what happened is to my way, conceptually, the body tries to establish a homeostasis. It reaches some normal. So it resets so to be able to tolerate the increased pressure without other findings. And there are other examples of this in medicine. Look, when we give people Diamox, people go and they have to urinate frequently, but after a while that the kidneys adjust and they stop, and also CO2 levels change with Diamox, but then after a while they tend to normalize. So it's one of those things that the body is great when it's normal at adjusting. So I wouldn't chase those patients. I didn't say I would ignore them. I would say, well, you know what? Come back and see me in 6 months. If you have symptoms, you call me. But since there is no problem, you're not worried about something exploding on you.
Yes. Another patient question. I have so the post is, my concern is having cataract surgery with bilateral papilledema. I don't know exactly how to interpret this. probably this patient at Papi at IIH, and she has also cataract. So, do you have
Yeah.
any comment on that?
So again, of course, we're not the treating or examining doctor, so it becomes a little complicated. But of course, as I mentioned, the vast majority of patients with IIH are younger patients, which is not the age of cataracts. So the question is always going to be first, how significant are the cataracts, or is the visual disturbance related to the IIH? Okay. And you can have more than one disorder. We know that, but we also know that the chance of having two disorders in the same organ system goes down low. So we have to figure. So the question is, to me, if you have that type of complicated, you need to get other opinions before you do elective surgery. But cataract surgery by itself should not perturb or disrupt the papilledema or the intracranial hypertension.
Okay, but the two populations, the cataract population and the IH population, are so different in your opinion that you are having a doubt on the diagnosis.
Well, I think it's always good with elective. It's always a pretty good idea in medicine if you're having elective surgery and you have any questions to get more than one opinion.
So, a patient who is asking us, I am a patient with IH and I have had adverse reaction to both Diamox and Topamax. I experience metabolic acidosis on both of these medications, even with a sodium bicarb supplement. What are other medications and treatment options that are available?
Yeah, that's very good question, because we do face that because there are people who are allergic to Diamox. Topamax is a similar drug to Diamox. Actually, if you look at this, there are case series, but no good clinical trials that show the effectiveness of Topamax in IIH, by the way. People will reach for it and use it, assuming it should work, because it's an appetite suppressant as well. But just so people know. So the fallback drug that we use is Lasix. And Lasix, we know, will reduce intracranial pressure. There's been for other causes. There's, again, no clinical trial. But in our study of severe disease, we allowed Lasix in. Now, how effective it is, I don't know. But but that's an indication. If you're having significant IIH problems and you can't lose weight, then a failure to treat medically is a good indication to do some type of interventional procedure. It's what we do this. Look, for those, there are probably not too many eye doctors on the phone, but this is way in glaucoma patients who don't take their drops, don't have compliance with glaucoma. You're doing an early surgical intervention to prevent the vision loss from glaucoma, because it doesn't matter the reason why. The medicine is not working because the patient can't take it. So you do surgery. That's just the judgment of how physicians, I think, should think.
Another question. Is it safe to combine Diamox with topiramate?
No one knows, and I wouldn't do it. I wouldn't do it. And there's no point. There's no point doing it. And there's no studies to show they both supposed to theoretically work on carbonic anhydrase as inhibitors, but I see no reason to do it, and it makes no sense to me. It's like adding in when people have epilepsy and people add, before they get to the top level of one drug, they add in the second and third drug, and people end up on a polypharmacy situation, never knowing whether one drug could control their epilepsy. It's the same thing. Just fundamentally against that.
Very interesting. Sorry, I have a question, but do you have any idea what is Zoladex?
What's that?
Zoladex, Zoladex.
No.
Okay, I will investigate because it's a patient who think her physician told her that IIH could be linked to long-term use of Zoladex. So we will
Oh,
have
I
to
see.
check.
So we'd have to. We'd have to. So we are asking. So that's do. Spell. Let's spell it for me. It's what?
I'm doing a grok search, Zoladex, to try to understand what is this
Yeah.
new
Well,
medication.
you got an idea, but spell it for me.
Zoladex.
No, the answer is no. Zoladex is basically a hormonal therapy used in cancers, and the answer is these type of drugs can cause hypercoagulability and can cause venous sinus thrombosis.
Mm.
That is not what we call IIH. So that's a different disorder. And no one's asked the question, but we presume, and we presume probably incorrectly, that everyone in the audience knows IIH it's idiopathic intracranial hypertension, which means that you've ruled out other causes, something compressing the venous sinus thrombosis, drugs that induce intracranial hypertension, tetracyclines, vitamin A derivatives like retin A. So those we don't call IIH, we call them drug-induced or some other thing induced intracranial hypertension. And the literature is very confused about this because you always want to take the proper history to make certain that the patient has what you think they have. Now, if you look at the neurology textbooks, unfortunately, there are a lot of mistakes in the textbook that say like steroids, glucocorticoids cause IIH, or birth control cause IIH, but they don't cause IIH. Oral contraceptives increase your risk for venous sinus thrombosis, and that causes intracranial hypertension secondarily. So there's a lot of confusion because there's not a lot of rigor in reviewing the literature, and case series are just case series. They give you an idea. They might be right, they might be wrong, but case series without really doing it prospectively and really rigorously can lead you to the wrong answers. So anyway, the answer is that I don't believe that person has a risk with the Zoladex.
Mm. What are the medications that are known to cause IH?
Well, that are to cause intracranial hypertension. I'm going to say I want to differentiate. So it's drug induced. So big doses of vitamin A, low chronic, the retin A, growth hormone in kids can cause intracranial hypertension. Those are retin A is a vitamin A derivative. And also retin A's are used in childhood leukemias. So those are the big ones, and in some families, tetracyclines. And what's nice about those, if you identify the cause and you're certain that the patient is otherwise okay, you could probably get away with giving them some Diamox to treat them transiently and take away the inciting agent, and they will get better in about 6 to 8 weeks and it doesn't come back. Oh, I have one other one. So patients who have been on chronic glucocorticoids, prednisone, stuff like this, for inflammatory disorders, sometimes the abrupt withdrawal can cause intracranial hypertension. And so reinstituting the steroids and slowly tapering them over a longer period of time makes that go away as well. But the list is pretty. I mean, there's a laundry list that's longer than on my arm, but pretty much how true the case reports are varies.
Question that is kind of very long answer. So the patient has IH and she types, my neurologist suggested that I lose 15 to 20% of my body weight, but a lot of people say that they still experience symptoms and if not worse, since they lost weight. Do you have any comment on
Yes. Well, first of all, you have to be very careful about when you go online and in chat rooms, you have all kinds of people who say all kinds of things. Just like medical literature, it's uneven and you don't know what's really real and what's not real, and patients who may have been misdiagnosed. Now, I don't, of course, again, we're not your individual doctor, and I don't know what 15 to 20% means, but we do know that if you have from the research that if you lose whatever your excess is above what would be considered a normal BMI, if you lose about at least 10%, that patients tend to get markedly better. Does everyone get better? No. Just like not everyone gets better from a shunt, not everyone gets better from a venous stent. There's no 100% therapy for any disease. But patients don't get worse from losing excess body weight. There's no evidence or suggestion of that at all. So they may feel poorly because they may have felt badly, because a lot of things go with losing weight. But in general, as Pierre and I will say, this is part of the major healthcare problem in the United States, is being and in the Western world, and any place where there's money, is being overweight is driving a lot of bad diseases. IIH just being one of the early ones, and relatively uncommon disease.
So this question is not coming from the audience; it's coming from me about weight loss. I wonder if weight loss is not more effective when the IH is recent, while on the opposite, if the symptoms have been there for a long time, it looks like there is an inflammatory state that you are not going to reverse easily, and things have been changed. Maybe the aquaporine system has been disrupted for so long that even if these patients lose weight, they will not improve or minimally improve their IH.
Yes. So it's an interesting theory, Pierre, but no one has addressed it. So actually, that's a very if there were I don't know if there are if anybody's done any pilot work on this. And again, your impression is your impression, but I don't know. I don't know. And I will tell you is, however, the dangerous part about that comment or theory is that patients need to lose weight for their general health. So telling them even if you lose weight, you won't get better, won't translate into better health care, right? Right.
Yeah.
And I've seen, by the way, and again, I know we're on an open type of thing. I've certainly seen people who have not lost weight and they've gotten better. I've seen it. Have I ever written about it? No. Will I ever write about it? No, because it sends the wrong message to the general population and the doctors. That's why I keep that under my hat. That's facts that will potentially harm people. I did see something flash across the screen I'd like to address. Someone said, how often you repeat the spinal tap? And for everyone out there is hopefully never. And the old way of treating this, way back in the 60s, there was a guy, I can't remember his name, at Columbia, and then he became chair at Tulane, and he used to practice that way. And I said, that's the best way to lose your practice, because but patients, we have good therapies and good medication. You don't have to know the exact pressure, and like I said, the exact pressure is only one point in time. which fluctuates tremendously. So the only reason to repeat the spinal tap, and the only reason, is if someone is in a lot of trouble having debilitating headaches that you can't control with medication, or losing their vision, and you're doing it as a temporizing procedure before you move to an invasive intervention, whether it be stent or shunt. That's the only reason. So people say, oh, I did the spinal tap and the pressure was X. And I came back and I did the spinal tap 3 days later, which is what they used to do, and the pressure was in the normal range. I'm happy. And I'd say, are you kidding me? First of all, when you make a hole in the dura, the rent stays open, and so it could just decompress for a week or two, or you could be tapping an epidural pocket of spinal fluid. So it's an inaccurate measurement for no purpose. So I want to just be adamant about this. No one who is an expert in IIH does repeat spinal taps unless it is 100% necessary. Further is we're pretty much uniformly around the country, people doing lumbar punctures under the X-ray guided fluoroscopy, because it is very difficult to do an LP in a very overweight individual. And
painful.
And well, very difficult and painful. And I don't believe it's justified. So that's why we do this. But then you're saying, okay, how many times are you going to expose this person to fluoroscopy and additional X-ray just to do an unneeded procedure? Okay, so I'll get off my soapbox about that.
Another question, very different from the audience. I was diagnosed with IIH 2 years ago. I was taking medication and lost weight. I was seeing a neurologist and a neuro-eye doctor. I have overcome and officially been cleared of IIH, and I have not seen a doctor in the last year. Question is, can my IIH comes back? What step can I take to ensure I do not start having IH symptoms again? Question.
Yeah. Well, I think that once you have such a disorder, you should touch base with your neuro-ophthalmologist, periodically, once a year, once every other year. But since you got better because of the weight loss, and that is once you've reached what would be considered the target weight for you, then you should know that you shouldn't put the weight back on. Not that you guarantee that you will have an IH return, but there's a significant risk that you will if you put the weight on. So I liken this to cancer. Someone has lung cancer associated with smoking, and they cure the person, they take out a lung, and they cure the cancer, and the person's still smoking. He said, well, they took out my cancer, but that risk doesn't go away. So why would you go back and do the same thing that induced the cancer to begin with? I say, that's how I talk to the patients. I say, so you can't be X number of pounds, you have to be in this weight range, and you have to do what you need to do to mitigate, to reduce the risk.
Actually, that's a question that I have that I want to ask you. When I was negotiating with the FDA how to do the reverse study for the reverse stent, I tried to find in the literature how long does IH last? Is it a disease that you are going to have for life? And I just could not find the answer.
So there's no great literature, again, because once a patient becomes either controlled and they have minimal problems, or they have resolution, no one goes back and repeats a spinal tap. And even in this national study, it was a research study, only 50% of the patients consented to do a repeat lumbar puncture at a year. Okay, or six months. So people are not going to volunteer to do this. But there are just, again, there's a literature of isolated cases that show the intracranial hypertension probably persists for a long time. And like I said, the body readjusts. It probably remains. But if it doesn't interfere, what's the difference? You know, what's the difference?
Okay. There is an interesting question that I think I can answer. Um, a patient will say, when I was first diagnosed with IH, I only had stenosis on the left side, but in my most recent MRV, I have it on both sides. Could IH be causing the stenosis as opposed to stenosis causing the IH? That's a very, very deep question. I have explored the option of stenting, but there is no guarantee it will work. Um, uh,
You answer.
so, um, yes, it's the chicken and the egg question. Is that IH causes venous stenosis, but venous stenosis also increase the symptoms of IH, and that this is a vicious circle that can be broken with treatment. It can be broken with stenting, with a shunt, or if medical therapy work, with medical therapy. But the two are linked. I mean, venous stenosis and IH are really linked. And it is really rare to have a patient with IH who has severe symptoms and who do not have a stenosis. And on the other hand, um, if you have a stenosis, stenting the stenosis will improve your symptoms. It will not cure your IH, but it will improve your symptoms. Now, having a stenosis on one side and developing it on both sides, it's really the addition of the drainage from both sides that you should consider, because in IH, the stenosis of a sinus can really be fluctuant, and so this should not worry you too much. It's really the global rate of stenosis that is worrying, not the fact that one sinus is stenosed or not. Anyway, we will not place a stent or do any surgical intervention just because there is a stenosis. We will do it only if your symptoms are severe. Do you want to add something, Mark?
Yeah. I want to say is that so it's like you said, it's a very insightful question, and I will say is that if, and again, this patient obviously knows his or her way around the issues, is that if you have a unilateral stenosis and you have very robust, good developed venous sinus on the other side and it was open, then it's likely that you just had IIH to begin with, and you have a secondary venous stenosis in the first side. And with chronic pressure, the point where the transverse sinus becomes the sigmoid sinus, that's a choke point for where the intracranial pressure can cause compression, literally external compression on that. So that probably you always had my guess is you always had IIH, and now it's not surprising that you developed stenosis on the opposite side because it just took some time. Not everything happens in the body symmetrically.
Well, we are going to open a can of worm here. Is IH in children. Good morning, doctor. My daughter was diagnosed with IH at 8 years old. She's 10 now, and she's on 1 gram of Diamox. Is there always a reason or cause that lead to IH? I suppose the doctors have told me plenty of time that there is no reason for this condition. I appreciate your time. So IH in children, that's very
Yeah.
difficult.
Very interesting, very difficult, and not exactly like adults. Pre-puberty, post-puberty IH, teenagers are the same as adults. But pre-puberty, no one knows what caused this. There's a higher rate, still more women, but many more boys get it. And not everybody is markedly overweight. Although being overweight does play a role. And so they search for other metabolic causes that can cause intracranial hypertension. But that's why they call it IIH. It's idiopathic. If the child, and you always want to be careful, is overweight, you want to have some type of way to modulate the diet. And obviously, we don't want to get into the eating disorders and things like this. But that's what happens. And so no one knows what this is. But I have to tell you, Pierre, I'll throw out a theory. You're talking about inflammatory disorders. What happens? What happens? The difference between a kid and an adult woman, besides having menstruation and hormonal changes, the other thing that happens, autoimmunity changes at puberty. And so we never looked at the microRNAs and things like this to have the kids versus adults to look for if there's any inflammatory component to this, because that's the only thing that changes at puberty, that besides the hormones. And of course, there's never been a suggestion that this is an inflammatory disease, but we do know that there is neurological inflammations that don't show up in a lot of diseases. But I thought about this, but we never studied it to look at, because it's a far out theory, but it's based on like what happens. So the kids are treated in the same way as the adults in a way. No, I don't think anyone's going to do a venous stent in the child so easily, but they're given medications like Diamox. They're asked to control the diet. But kids who have vision loss get shunts or optic nerve sheath fenestrations. But they do that. We do treat them just as aggressively, because we don't want them to have a lifelong, life with poor vision and not being able to see, and that would help to hurt their education and any type of development. So I'm sorry, I can't. That's a complex question for kids.
Personally, I think that IH is secondary to in some kind of inflammation, and inflammation induced by obesity in adults, and in kids maybe because we are exposed to all type of contaminant in our environment that did not exist 50 years ago. And even in kids, and you're right to pointing out that IH in kids, it's not as linked to weight, to obesity, as it is in adult. And it's a mechanism different, but I wonder if it's not pure inflammation in children, even more than in adults.
Well, that's right. Well, that's why, again, that remains to be studied.
So the question that everyone is wondering about: are GLP-1 used to help treat IH? Question mark.
So let's talk about GLP-1 and agonists, or let's talk about more really the subclass semaglutides, right? The semaglutides have, to me, I have no stock in any of the companies, unfortunately, but these will be considered some of the great breakthroughs of the 21st century for treating so many different obesity related illnesses that really are terrible for the population. So as the chair of Nordic, people said we should run a study, and I said, I said Novo Nordisk doesn't want to hear from me. They don't have to fund a trial to test their drug, because they're already selling the drug faster than they can print money. So you understand, pharma and medicine, medical doctors and medical investigators converge when it's convenient for the companies, and we're happy to participate as long as we can do good quality work and ethical work. But I never approached the companies, and there have been a couple suggestions. There's been a couple case series where they said, the IIH got better on the GLP-1 agonist, semaglutides, but that would be expected because we already know that happens with any cause for weight loss. The issue would be if you were going to do a study, and I'm thinking about study design, we'll put it out there because if someone wants to work with us, and that is, you probably could compare chronic IIH and new IIH and see the relationship of induced weight loss. For this would be an interesting study to do. Or you might compare the semaglutides to other more conventional ways of losing weight and see, is there anything different? Now, there is a research group in Birmingham, London, that has done a lot of work in their experimental models and found that GLP-1 agonists at the level of the choroid plexus have a role in reducing CSF, separate and distinct from losing weight. So it's possible because these drugs have multiple mechanisms and places that they work. But the work hasn't been done. And unless the company is going to bankroll this, it'll never get done because clinical trials are extremely expensive. But we could design a trial. I could design a trial in a day that would answer the question that we're interested in. And at the same time, of course, from our point of view, collect the inflammatory markers and other things with the microRNA and do the things we didn't know about when we first did our study.
So we have one more question, very important, window into the future. Can we expect any invention or regeneration of optic nerve through stem cell or other advanced therapy?
So the short answer is not in my lifetime. And so I had a running battle with the NEI, the National Eye Institute, about this more than 15 years ago. They said they was going to happen, and I said there's some important stumbling blocks that they have not been able to overcome to get the neurons to grow back, to stem cells turning into neurons, to make the connections in the retina and grow back through the optic nerve, through the chiasm, to the first relay, which is called the lateral geniculate. There's no one's come even close. Okay. And so in animal models, it happens in amphibians, but no mammals. And by the way, they're just for those people out there, there are a couple groups out there that are charlatans that say they can do this and will take your money for a lot of money to do this, and they somehow get away with it. But there's no credible mammalian work. Again, a rat, a guinea pig, a mouse, dog, monkey, nada. There is an interesting work being done on electrical stimulation along the optic nerve to induce the optic nerve fibers to grow back to the brain to the proper place, being done in a rat. And I know that person, this investigator is really smart, but it'll be 15 years before she's ready for a clinical trial if the work continues to go the way it's going. So the short answer is no, and that's the explanation why. And be careful. Do not, if you have money, again, like I said, for elective surgeries, get an opinion from people who know rather than just, even if you're desperate, don't throw your money away.
And take risk.
Yeah.
Thank you very much, Dr. Kupersmith, for sharing your encyclopedic knowledge about this disease and neuro-ophthalmology. Barak, do you want to conclude?
I would like to. First of all, I want to thank you both so very much for a really amazing talk, and thank everyone for joining us. Just a couple resources. We continually publish new information on the IIH Hub. There's great information for patients, as well as great information that's deeper for physicians. Anybody can go to either side, and we encourage you both to visit both sides. There's a newsletter that you can sign up for. We also take these webinars, and we put the full webinar recordings on our YouTube channel, and we also chop it down into more snackable pieces of content, some of which are quite popular. So I encourage you all to go visit. We have one more, we have many more, but our next webinar is with Dr. Jamie Wright, talking about VP shunting. The exact time is not yet known, but that will be on November 6th. So please come to if you're on the email list, we'll make sure you know about it. And if you're not on the email list, please come sign up here and you will be able to find out more about the next webinar. So thank you all very, very much, especially to Dr. Kupersmith and Dr. Gobin. Thank you so much.
Thank you for having me.